Awesome. Hi, everyone. Welcome back to week 3 of McMedHacks 2023. Today we have our speaker, Dr. John Kildea from McGill University to speak with us here today. I'm going to do my usual housekeeping at the beginning. So here we go. So as I mentioned, this is a week 3 of the 8-week series here. And as usual, if you have any questions, feel free to email us at medhacks2021@gmail.com. Just some reminders that we recently got some questions regarding the certificates for phase 1 and phase 2 in terms of the attendance for 70% of all sessions, and for each session you must have attended for more than 30 minutes. And if you didn't get a chance to attend live, you can, we will upload the quizzes for you, and then you can do that instead of to catch up on the live session that you missed. So today we are at week 3 of the phase 1, which will constitute today's seminar and tomorrow's fully supervised medical image segmentation workshop given by Dr. Puria. I'll do more introduction of that tomorrow, just so you can go on our website at the McMedHacks 2023 program. And today we have Dr. John Kildea. And we have 2 mentors for this week as well. If you're in the audience, feel free to say hi and turn on your camera. So this means that we'll have another tutorial session during the week given their availability. They are Hossein and Valipen. I'll just do a brief introduction of them. Hossein is currently a master's student in computer science at University of Calgary under the supervision of Dr. Farham Maliki. You might remember both of them from last year if you were with us. His research focus is on applying machine learning and deep learning techniques to medical image analysis, currently working on utilizing the attention mechanism for medical semantic segmentation. And the second mentor that we have this week is Valipen, and he is a first-year PhD student at McGill and a researcher and student researcher at Ubisoft, where he focuses on applying reinforcement learning techniques to gaming with a strong focus or a strong foundation in computer vision and machine learning, complemented by research work in medical image and speech. So thank you both, Hossein and Valipen, for joining us this week and give your valuable time to help our participants. So without further ado, I'm going to introduce our speaker today, Dr. John Kildea. He is a medical physicist at McGill University Health Center, MUC in Montreal, and an associate professor of medical physics at McGill University. He's also an FRQS co-chair in AI and digital health, director and co-founder of the OPAL Health Informatics Group, and also the chief architect and designer of the award-winning OPAL patient portal platform and principal investigator of the Quebec Smart Care Consortium. So thank you very much, John, for joining us today. You can feel free to share your screen now. We have some people joining in still.
Okay. Wow, the numbers have jumped in the last 2 minutes.
Yes, I'm going to actually just disable the waiting room now, so people can just join in. Great, okay. Go ahead.
So I will share my screen and I will I'll get started, and got a few introductory slides, so people who are still joining will not miss anything just yet. So thank you very much, Eugene, for that nice introduction, and thank you to you and to the organizers and Shirin for the invitation to present the work, the research that I'm working on. So I'm going to present on co-design and data sharing with a patient portal to facilitate AI research in healthcare. But really what I'm going to be doing is presenting on a learning health system, and not presenting on AI so much, but presenting on how we need to build infrastructure in order for AI to be useful in healthcare, because there's no point doing AI in a research context and it all working great and then it's not actually implemented. So there's some homework that needs to be done in order for our digital health solutions or AI solutions to actually make their way into clinical practice. And hopefully I'll give some tips on how that can be achieved with co-design. So I'll right away tell you I have some disclosures to make. So I currently have some funded research collaborations with the following industry partners: Roche, Novartis, Vital Tracer, and IMD Research. So I have ongoing research with these entities. I also want to be clear that what I'm going to present today is very biased in terms of my own personal experience. And it's influenced by my personal experience as an academic medical physicist working in radiotherapy. So it's quite heavily focused on radiotherapy at the McGill University Health Center, which you can see here is a picture of the MUHC Glen site in Montreal, and also my involvement with the Canadian Partnership for Quality Radiotherapy, the CPQR, and I'll be speaking a little bit about the National System for Incident Reporting in Radiation Treatment, which is essentially a real-world data database or data set, pan-Canadian. And also my work on the Opal patient portal that you mentioned in the introduction, and the Quebec Smart Care Consortium. So some learning objectives. At the end of this lecture, attendees should be able to explain what is meant by a learning health system, list 3 barriers to implementing the learning health system, and be able to describe the difference between stakeholder co-design, patient-centered design, and person-centered design. And these are key definitions that I believe are important to understand as we embark on building something that will be useful in the healthcare system. So building infrastructure where we can harness the AI technology that we've built and been able to put it into real world practice. Oops. So overview of my presentation, I'll provide some definitions of a learning health system, provide some historical perspective. Then I'll speak about stakeholder co-design. I'll present Opal, our patient portal, as an example of stakeholder co-design. And then I'll talk about stakeholder co-design in building a learning health system, some of the barriers and facilitators to that, and then presenting Opal as part of a learning health system, being what we like to think as a patient-centered or person-centered patient portal. And then I'll finish off with a conclusion and summary, which will include a quick overview of the Quebec Smart Care Consortium. Okay, so jumping right into it, what is a learning health system? And when I look at these definitions, I tend to go to the dictionary to break it down. So let's first of all look at what do we mean by system. So a system is a set of things that work together as parts of a mechanism or an interconnecting network. And there are many systems that we can think of. So we have operating systems. So we're all working in the computer science realm. So we have our various operating systems, whether it's Mac OS or Windows or Android or Linux, whatever it is. But we're also working in the biology and realm, and we know that we have various systems in the body. We've got the digestive system, we've got the lymph system, the nervous system, etc. Again, all the definitions of things working together as parts of a mechanism or interconnecting network. And then we've got the healthcare system. So the healthcare system is all the parts of the healthcare, the world of healthcare. So more of a definition on that: a health system or a healthcare system is a set of things working together as parts of a mechanism or interconnecting network. So keeping the same definition. And by things, we mean people, institutions, and resources. And with a goal to deliver healthcare services to meet the health needs of target populations. And this actually is the World Health Organization definition of a health system or a healthcare system. Okay, and let's look at that in a little more detail. So the people, institutions, and resources. So what are the building blocks of the health system? Well, we've got the service delivery aspect, we got the workforce, We got the information that is flowing around the healthcare system, which obviously we're very interested in from an AI perspective. We've got all the medical products, the vaccines, the technologies, which includes any AI technologies that we come up with and that we want to get in there. We've got the financing, obviously, all of this has to be funded. And then we got the leadership and governance that ultimately we need to be on board if we want to embed an AI technology in the healthcare system. And this definition is taken from the World Health Organization's Framework for Action 2007. And I'm going to put it into the context of Quebec. So I'm working in Quebec and working with the Quebec healthcare system. So in Quebec, we've got our service delivery, which is the Réseau de Santé et Services Sociaux, which essentially is the hospitals and the clinics, as well as the private clinics that deliver healthcare to the population. We've obviously got the healthcare workforce, which is either private or public, the people who are employed in the healthcare workforce. And we shouldn't forget the informal caregivers, who are a huge part of the healthcare system that often get overlooked. These are the people who are caring for their family and friends, often at home and often unnoticed, but who do need help. And there are many AI technologies now that are working with caregivers. Of course, we got the information that is flowing through the healthcare system, whether that is knowledge in the heads of the people that are working, the literature that we all access to make use of, and of course, the personal health information, the data of the patients who are being treated in the healthcare system. And the medical products, vaccines, and technologies, that goes without saying. The financing that comes from the government in our case, but there are also private clinics and there are also private healthcare systems where the financing comes from the users of the system or the insurance companies. And here in Quebec, we got the leadership and the governance. So we got leadership within each institution, and then we got the ministerial leadership in the Ministère de Santé et Services Sociaux, which is politically driven because it's a public healthcare system. So I've just mentioned that in Canada, we have essentially 10 or 11 healthcare systems because each province in Canada has its own healthcare system. So often we talk about the Canadian healthcare system, but in fact, there's multiple Canadian healthcare systems. There's not one big system. Okay, and what are the goals of this healthcare system? Well, the ultimate goals, and again, taking this from the WHO Framework for Action 2007, the ultimate goals are improved health for the population, responsiveness, so be able to deal with health issues. And we know the last few years with COVID, responsiveness was a big issue. There's also social and financial risk protection, so whether it's with public or private insurance. And then there's improved efficiency so that we're getting good value for money. And all of these take access, coverage, and quality and safety. These are factors that need to be taken into account in order to deliver these overall goals and outcomes of the healthcare system. Okay, so that's the definition of the healthcare system, but what about the learning health system? And so let's look at the word learning. And from the Merriam-Webster dictionary, learning is the modification of a behavioral tendency by experience. And of course, in this MacMed hacks, you guys are dealing with machine learning all the time. So you guys are very well acquainted with the meaning of the word learning. But to break it down a little more is we've got some sort of desired outcome. So whether in case of AI, it's a model, you've got a behavioral tendency. So you're essentially building a model, you're comparing it with real world experience, you're making some modifications, then you're comparing again, making more modifications, comparing, and it's an iterative process where real world experience is being taken into account continuously in order to produce ultimately the desired outcome. So whether it is machine learning or in the case of the learning health system, it's learning at a global scale so that we're going back to these outcomes, these overall goals and outcomes, improved health, responsiveness, social and financial risk protection, and improved efficiency. Those are the outcomes of the learning process that we're interested in. So just adding those into the center there for a learning health system. These are the outcomes that we want to get through our modification of behavior, through our evaluation of our experience, and then it being a continuously iterative process. Now, I didn't just make this up myself, this concept of a learning health system. So I'd like to introduce a little bit of the historical perspective. And a lot of this comes from the US Institute of Medicine. And it started around the year 2000. So around the year 2000, or in 2000, the Institute of Medicine published this groundbreaking report called "To Err is Human." And in this report, they recognized that 2 to 4% of deaths in the US may be due to medical errors. So this is quite significant. This is not deaths in the healthcare system. This is people dying overall, that 2 to 4% of people might be dying due to medical errors. This led to an increased awareness of medical errors, and it prompted the adoption of incident learning systems, including, as I have a personal interest in, radiotherapy. So you notice the word here, incident learning, so a learning system, but to take into account incidents. So this is to find out what was causing errors in the healthcare system and to adopt and make changes so that those errors no longer occur. And I'm just going to mention radiotherapy, which is what I'm familiar with. And this is a diagram that I've taken from Logan Montgomery, who was a PhD student in my lab, a figure that he produced for his master's project. So this report, it prompted a lot of introspection, and around the year 2000, a lot of errors were being noticed in radiotherapy. So radiotherapy learning systems were built, and essentially incidents that occur in radiotherapy were being documented and going through a process of investigation, and then follow-up actions to make sure that the incidents don't happen again, but aggregating data into incident analysis, into databases, and then sharing these findings with the community so that the errors that were discovered, the remedial actions that were taken, that these can be shared and learned by the healthcare system in general. And at a Canadian level, this was done across the country, with pretty much all provinces participating in what was known as, or is known as, the National System for Incident Reporting Radiation Treatment. And I'm the chair of the advisory committee for this this organization. So I have a lot of interest in it, and I see how it operates. So I know it is very difficult to get patient data, to get data to be used for learning, for machine learning, for artificial intelligence. And I want to just mention this as an example of a pan-Canadian data system that is contributed to from lots of hospitals. So it is possible to get data across the country. And we've got about 80% of radiotherapy centers in Canada participating in this. So again, this started off with the Institute of Medicine in the US really identifying that errors occur, that we need some sort of system to learn from our errors so that we don't make those mistakes again. They then published another report in 2001, which was called Crossing the Quality Chasm. And this really brought the concept of quality to the forefront. So quality in healthcare, not just delivering healthcare, but having quality at the forefront. And this deals with the overuse, the underuse, and the misuse of healthcare resources and treatments. So not just incidents that occur, and it recommends improvements to the 6 dimensions of quality. And it identified those dimensions as patient safety, care effectiveness, patient-centeredness, timeliness, care efficiency, and equity. So this is way back in 2001, or more than 20 years ago. In Canada, we took this on board around 2000 as well, and we created something called the Canadian Partnership for Quality Radiotherapy. And the idea was to build into the pan-Canadian healthcare systems, and I emphasize the word systems again, a partnership that tried to bring these dimensions of quality together and work on a ground-up system or ground-up approach to improving healthcare quality in radiotherapy. So that was 2001, again, the Institute of Medicine. And then in 2007, the Institute of Medicine published this report called The Learning Healthcare System. And this is really where the concept of the learning healthcare system came from. So it started in 2000 with the report on errors in medicine. It moved to 2001 with the quality in medicine, and then ultimately bringing this all together as the learning healthcare system. And at that time, AI wasn't really on the tip of everybody's tongues as it is today. But the concepts were being built back then and are very relevant today. So the official definition from this report by the US Institute of Medicine is a learning health system is one in which knowledge generation processes are embedded in daily practice to produce continual improvement in care. And the learning health system is the modification of the delivery of healthcare services by experience to better meet the health needs of target populations. So it's really learning from experience. So it's back to the idea of the building a learning system for incident reporting, but it's more than that. It's building a learning system for everything. Eugene, I see there's a comment in the chat. Do you want me to address comments as we go along, or?
Is Christine saying it's a fantastic lecture?
Okay, no problem.
Yeah, we can answer questions at the end.
Okay, so you let me know. Okay. And as I said, this wasn't on the tip of people's tongues back in 2007, but artificial intelligence now is at the tip of our tongues, but the concepts still apply, really on building a knowledge generation processes that are embedded in daily practice to producing continual improvement in care. And really, when we're dealing with AI in healthcare, we do need to have continual learning, and it's continuous knowledge generation. So we are using data that is being produced live in the real world. Again, taking on this definition, and it's really by embedding knowledge generation processes in daily practice, a learning health system addresses the problem that most research findings take a long time to work their way into clinical practice. And when we deal with AI, we can't just have AI operating on clinical trials and then take those results and put them into the healthcare system. We need AI, our artificial intelligence algorithms, to be continuously taking data from the healthcare system and utilizing those data in the real world. So we need not for our research findings to take a long time to make their way into clinical practice, but we need them to make their way immediately into clinical practice in terms of learning from the data that are being produced at a continuous, in a continuous way. So again, it's integrate research and clinical care to facilitate continuous improvements in the desired outcomes. So these are the desired outcomes that we mentioned already, and the continuous learning from these. So the behavioral tendency that we're dealing with is the actual clinical care. The experience that we're dealing with is the real world data. And the modification and the evaluation are really implementing changes into clinical care, doing research, doing the data analysis, and getting those results, making the modifications to the clinical care so that we get modified real world data and have this continuous cycle of learning to improve our outcomes. Now, as I said in the introduction, I will introduce the barriers to making this happen. And there are many barriers in the real world healthcare system. The barrier to implementation of change is a cultural reluctance to change among healthcare professionals. So you will encounter this if you're doing any work in the healthcare system, you're working on an AI algorithm that you want to get into practice, you have got to be able to deal with the reluctance to change among healthcare professionals. And it's just a natural human tendency. The real world data, this is a huge problem. I'm not going to be able to solve this problem in one talk or even suggest how to solve it, but we have got limited data of limited quality, data that are non-interoperable, that are coming from many different siloed systems in the healthcare system. And if we really want to get that proper evidence to be able to do real world learning in the healthcare system, we're going to need to address this lack of interoperability, this lack of good quality data. And that's certainly a barrier to making this work. And then research, of course, there are ethical and or legal constraints to getting access to data. And in order to facilitate this, we need to deal with procedures for informed consent of patients, so that we can get access to their data and be able to make use of them in the algorithms that we need to or that we want to implement. Okay, so overcoming the barriers, and this is where I'm going to take the talk from being about the definition of learning healthcare system and how it applies to AI, to really being looking at what is potentially a solution to getting this to work. So that these barriers can be overcome by using co-design and by using stakeholder co-design. So what do we mean by all of this? So we want to design a system that works. And I refer you to this book by Don Norman, which is really the book on design. The design definition that I take is from the Merriam-Webster, but of course there's many definitions in the Norman book, where design is deliberative purpose of planning. So you're deliberately designing something, deliberately planning, sitting down and coming up with your design. In my words, it is think before do. So don't just do, which a lot of us tend to, we just go in there, we build our algorithm, and then we hope that it works. We build it and hope they will come. But it's much better if we think before we build it. We work with the end users, and we build it with the end users, and then it's more likely to be adopted. And this applies to AI algorithms and to AI technologies as it does to designing a waiting room or designing a hospital or designing a parking lot for a hospital. We want to bring the end users in. And I use the words participatory stakeholder co-design because you really need to have the stakeholders involved. So what is design in general? And this is not just for AI. It's not just for designing your algorithm, not just for designing your end user interface, etc. It's for everything. So this is a diagram I took from the Interaction Design Foundation online. Essentially, we want to empathize, so you need to think about it. You want to define what it is you want. You come up with ideas, you turn those ideas into prototypes, but then you make changes, you get feedback from the end users. Your prototype is going to change it multiple times. And then you ultimately build your solution, you test it, you find that it doesn't do what you want it to do. You have to redefine it. You have to come up with new ideas, new prototypes, and you iteratively get to the point where you can test your system and go live with it in the real world. And what's very important about this is that things become more expensive as you move towards the right. So it's cheap to sit down and think. It's expensive to build a system, test it in the real world, and find out that it doesn't work and then bring it back and have to make changes to it. So we want to do as many changes as possible up front on the left side of this diagram, so that when we get to the right side, as few changes are needed as possible. And a prototype and a mock-up is much cheaper than the real thing. So let's make as many changes on the cheap components, the cheap versions of our system. Okay, and participatory stakeholder co-design is also known as participatory design, co-design, cooperative design. You can go out online, you find lots of definitions of these. But essentially, it is a design approach that actively involves those who are stakeholders in the final result, in the design of the process that will produce it, so that the end users are part of the design process that will produce the process or the product or the technology that will produce the outcome that they are interested in, the outcome that they will be affected by. Okay, and who are the members of a co-design team? And I refer you to this book by Kellyanne McKersher in Australia called Beyond the Sticky Notes. And the members of the co-design are essentially the stakeholders. So these are people with lived experience. So if you're building something in the healthcare system, you want to have patients around the table, but you also want to have the physicians, the clinicians, all the workers in the healthcare system who are going to have to interact with whatever it is you're building, the technology that is going to be using AI. You want to have everyone around the table. So it's people with lived experience, and it is professionals. But even more than that, it's good to have provocateurs as part of your co-design team. And these are people who don't have a stake in your system, but because they don't have a stake in the system, they can really think outside of the box, and they can bring you fresh ideas that people who do have a stake in the system might not be able to think of. And this is something that I hadn't thought about before until I read this book by Kildea and McKercher, that really brings home the value of involving provocateurs in your system, in your design process. And students are great examples of provocateurs. These are people who have not yet, some students have gone through the healthcare system as patients, but many people don't, and they have fresh ideas, not biased in one way or another. So make sure you involve lots of people in your design. And co-design is extremely important in software development. And this has been recognized for a long time. So this is I refer to a report here called the Chaos Report by the Standish Group in 1994. And they showed back then that a staggering 31% of projects will be canceled before they ever get completed. And this is true in AI. And we see this so often with startups that create AI products and technologies that they go bust. They don't make it into practice. It's a lot of this comes down to not including the end users in what they're doing. And I will show you here from the Standish Group. These are the findings they had in 1994. And in fact, this group produces reports every year. And it's still the case that project success factors, projects succeed when they have user involvement, when they have the executive management support, they have ownership. So when people are involved and really involved, projects succeed. And when people are not involved and not supporting it, these are when projects fail. And so this is very important to take into account, that you need to have co-design. And by co-design, you have the end users involved, you have all the stakeholders, and you have the people who will use it, the patients, but also the professionals. So the executives and the people in the hospital who will need to work with your system. So in healthcare, I'd like to just give a few definitions of design, because you hear these words, patient-centered design, patient-centered care, brandied about a lot these days. And it's not as simple as that. So patient-centered design is design where we put the patient's needs in the center. And I say we put the patient's needs in the center. So we bring all the experts together, and the experts really say, we want to do this for the patient. And we really think about a solution for the patient. But I say for the patient, not with the patient, which is very important here. So this is patient-centered design. The design team strives to ensure that the needs of the patients are centermost. Whoever the project being designed may or may not have been identified by patients, and the design process may or may not involve actual patients. So the next thing is person-centered design, which again is the same concept, where we're putting the patient's needs in the center as a person. And this is concept of treating the patient as a person, not just as a patient. So recognizing that patients have lives, they have jobs, they have families, they've got more than just their disease that is being treated. But again, it is the members of the team getting together and thinking about the patient and putting the patient at the center. Stakeholder co-design, again, is the involving the stakeholders in the process. And we recognize that a patient is a stakeholder in the system. So when you do stakeholder co-design, you are bringing the patient in. So it's really co-design. It's not just design. So I've talked about patient-centered design, person-centered design. Now I'm talking about stakeholder co-design. This is co-designing the system with the stakeholders involved. And this is where patients, being stakeholders, are part of this co-design process. And this is very important, not just for building a solution that uses AI in healthcare, but it's for anything. If you're building a new hospital and you're designing a waiting room, you really should have all the stakeholders involved. Does it work for the clinicians? Does it work for the patients? Is it a comfortable setting? Don't just build it thinking that you are building it for the patient, but bring the patients in, have them part of the design team from the very start. And even have patients help you to decide what needs to be designed. Does the waiting room need to be designed at all? Maybe there's other ways of doing it. Have patients involved from the very start as stakeholders, but not just patients. You need everybody as part of the team. And involve them as equals, not just as a token patient who's sitting at the table just to give their rubber stamp. No, you need to really do it with patients as equals. And I want to just highlight the importance of co-design in e-health software development. And this is an example that I took from a paper by Tang et al. 2018, where they built a system called Care Connector in Ontario. And it's a really nice paper that highlights how they involved clinicians in the design of a real-world system that was going to be used by clinicians. So in order for clinicians to have something that is successful and something that they will use, you need to have the clinicians involved in the design. So if you're building a tool that you want clinicians to use in the healthcare system, make sure that you have clinicians involved in your design of that system before you go live with it, so that you're meeting their needs. And this is where I'm going to segue into talking about the project that I have been involved in, which is the Opal Patient Portal. And I'm going to talk about it as an example of stakeholder co-design. And to get started, I'd like to highlight that this was a project of co-creation. And it started in about 2014, and these photos are probably from 2014, with a patient. So the patient was Laurie Hendren, who was a professor of computer science at McGill and a cancer patient. So Laurie had lived experience, and it was with Dr. Tariq Hijal, who is a radiation oncologist, who is a professional in the healthcare system, and myself as a medical physicist and also a professional in the healthcare system. So already we had stakeholders involved in the creation of the solution. And by having these stakeholders involved at the very start, Laurie was able to ensure that what we were building was person-centered, that took into account the needs of the patient, not just by us thinking about it, but by her being there, identifying as an end user, as someone with lived experience, what should be there. It also ensured that we had clinician acceptability, because Tariq is a clinician, and he was able to identify what clinicians would need in order for them to give their buy-in to the system. And then I was there as an informatician, as a medical physicist, and I was able to say, yes, this will work or this won't work from a feasibility perspective in terms of the informatics involved. So having these three components at the start was crucial in order to make this work. And we had a number of design challenges that we had set out. So a number of requirements that we knew we would need from the outset. So we knew we would need multimodality. We needed on Android, on iOS, on the web. It's a patient portal, so it needs to be personalized with patient's own login. They're getting access to their own data. It needs to obviously be secure and confidential. We were building it in radiation oncology, but we knew that in order to be sustainable, it needed to be generalizable outside of radiation oncology. We were building this in Quebec, which meant that we had to have it multilingual with French and with English. And then ultimately, we wanted something that was going to be person-centered. And Laurie really recognized this, something that recognized that patients are people who want to get access to their data. And so we did bring all the stakeholders together. So from the very beginning, we had obviously clinicians, patients, and informatics specialists, but we also brought together the security and governance team at the hospital, the legal team. We had buy-in from the administration. We had a hospital IT team and cybersecurity involved to make sure that we were doing everything in the right way from that perspective. And we also involved students who we think about as the provocateurs or the future stakeholders of the system. And bit by bit, we built a solution and released it into the real world. So here's a timeline of where we got to our pilot release. So we built a prototype. We involved patients with surveys and with focus groups, and we made big changes to the system, and I show you that in a moment, with the feedback from our initial patients. So having a patient on the team was not sufficient, because that patient is just one person who can bring their perspective. So it's important to get broader feedback via surveys and via focus groups. And as you can see, bit by bit, we built the real thing. We did end user testing with select patients, with students who worked with fake data. And then ultimately we got our security and governance and legal team to give us the go ahead to be able to release it. And then we released it in the real world, but we continued to have focus groups so that we could get feedback as we are going along. And this is a figure that I published in the Journal of Medical Internet Research in 2019. And here you can see an example of one of our focus groups where we had patients, and we worked with patients to better understand the initial prototype that we had. And I want to show you how this changed. So this is what we'd put together initially before the focus group. And you can see it looks okay, but it's got this hamburger menu at the top left. And after the focus group, it really changed dramatically. And one of the biggest changes was a lot of the patients didn't notice the hamburger menu at the top left. So they were just working with what was on the screen in front of them and not quite understanding that there was a menu of lots of additional things. So we moved the menu to be tabs along the bottom, and then it was clear that the menu was always up front for the patients. And this was very valuable feedback from the end users. And so I think we could have even done this sooner. So as soon as possible, if you're building a solution that you have end users going to interact with, make sure that those end users give you feedback as soon as possible, even at the level of a mock-up, even at the level of having your solution drawn on a piece of paper and presenting it to a user on a piece of paper. And I know this seems a little abstract or a little bit disconnected from building an AI tool, but at the end of the day, all AI tools, in order to be useful, need to be used by end users. And so if you want it to be used by an end user, make sure that it's got a good user interface with good input from the end users. So this is the end product that we built for Opal, and this is used by about 5,000 patients at this stage, and soon, hopefully, a lot more. So it's a patient portal that gives patients access to their healthcare data, such as their diagnosis information, their appointments, clinical questionnaires, and also research questionnaires. And here's an example of a questionnaire. So questionnaires are very interesting because they allow us to get data back from patients, not just giving patients access to their data, but also getting data back. And we're also able to inform patients by sending them education material that is tailored to their disease and to their treatment. Because with the data that the system already has, we can tell whether it's a breast cancer patient or a prostate cancer patient and where they are in their treatment. And we can send them education material that is tailored to their situation and arrives at the right time. And I mentioned this paper a few minutes ago. This is the paper that we published in 2019 on the design and development of Opal as a person-centered patient portal, and how we did it with participatory stakeholder co-design. So even though this is a patient portal, I stress that this concept of co-design is really important for anything that is being used in the healthcare system. And again, here, bringing you back to the points about how do we build a learning health system and what the barriers are, I'd like to mention how stakeholder co-design can be used to deal with these barriers. So these are the 3 barriers we identified: reluctance to change, limited quality or non-interoperable data, and ethical and legal constraints. So cultural reluctance to change among healthcare professionals, that's human nature. So make sure that the healthcare professionals are involved at the very start. Make sure that the clinicians are around the table. Make sure that the hospital administration is there. Make sure that you have future stakeholders, so students that are understanding, medical students who are going to be the future clinicians. Make sure they are there so that they understand how things are being put in place today. So this is how we can foster change. Limited quality or non-interoperable data. Well, make sure that you've got the informatics specialist, that you've got the hospital IT team. Make sure that they are around the table as well, so that they can help identify the problems and help identify the solutions to those problems. And the ethical or legal constraints on amending informed consent procedures. Make sure that you have the legal team at the hospital. You have got the research ethics team, security and governance, etc. These people need to be around the table working with you. And you can see that I kept patients and clinicians. That I kept patients, clinicians, and informatics specialists there the whole time, because they have important input to give at all levels of these barriers. And so I'd like to explain how Opal as a patient portal can be used as part of a learning health system, and how it can facilitate data and data sharing in healthcare. So what we have built with Opal is a tool to empower patients with access to their data, but also to be able to report their symptoms and to communicate with their clinicians. So it's a way, it's a two-way street. It's about getting data to patients and getting data back from patients. For clinicians, it's the tool to manage their waiting room, to manage their virtual clinic, to have a dashboard, to be able to set up the rules for which patients get which information, and of course, to be able to look at those data that are coming back from patients. And then for research, it's about working with patients to recruit patients with a tool that is in their hands, to be able to access patient-reported outcomes. And as we're building Opal, or trying to build Opal in a multi-institutional setting, it's about getting data to patients from multiple institutions, and then allowing patients to donate or to share those data with us in a research context, so that we can start to do powerful AI research on deep data that is connected across healthcare institutions. So very quickly, this is what we have for Opal. It's a personal health dashboard for patients. We've got it's GPS enabled, so patients don't need to wait in the waiting room. When they come to the hospital, they can check in and they can wait in the cafeteria, or they can go to the bathroom without missing their call from their doctor. And we will call them in, the doctor will call them in with a notification on Opal when they are ready. It provides patients with access to their medical data, with all the data explained. For example, the appointments are explained, provide a map of where to go for each appointment, and an explanation of the appointment, so that the patient is coming prepared to the appointment. And it's about empowering patients with data, with knowledge of those data. So not just dumping data at patients, but providing explanations about the data. And we refer patients to this nice website by Lab Tests Online that explains each lab result in clear language. And it's about educating patients and getting data back from patients that is the questions are tailored to the patient's experience, and the education material is tailored to the patient's experience. And then linking it all together as part of the clinical workflow, so that it's useful to the clinicians, and that they're able to use it seamlessly in their clinics. And so we've done that by having kiosks in the waiting rooms, TV screens in the waiting rooms, but also patients can check in, they can wait, they can get notifications on their phone when they are waiting to fill out questionnaires. And so when they go to see the clinician can call them in using the virtual waiting room, and then the clinician has access to the data that have been produced by patients in the waiting room by filling out those questionnaires. And it's all managed in the back end with a publication manager that sets up which questionnaires are sent to which patients, which education material are sent to which patients, how the lab results are explained, etc., etc. And as I said, it really needs to be a two-way street. And so we have been working on a project that we call Partage. And this is really where things are starting to move into the AI domain, where we need to get data. We want to get as much data as possible. So this is a project that stands for patients and researchers team up and generate evidence. But Partage means to share in French. And it's really about patients giving consent and sharing their de-identified data with us for research, and getting those data from multiple systems via the patient. And we've had a project using the blockchain to really try to manage this. I'll show that in a second. And again, for the Partage project, we're using stakeholder co-design, where we have involved patients in the design of the consent form, in the design of the way that we do the data sharing, getting patients to participate and to understand it, and doing pilot studies and doing it in an iterative process. So this has resulted in a research menu being added to Opal, and this was the master's project of Kayla O'Sullivan-Steban in my research lab, and it has allowed us to add a new menu in Opal that lets patients see what studies are available that they can participate in, to be able to fill out research questionnaires as opposed to just clinical questionnaires, and to fill out consent forms to give access, give researchers access to their data. And we are expanding this to allow patients to say which data they're comfortable with sharing, and allowing those data to be shared in a multi-institutional context as we get the solution installed in multiple hospitals. We've also worked, Anton Glader put together a blockchain solution to keep track of patient consent. So when we get patient consent to participate in research studies, to gather those data together, we use a blockchain to keep track of it, blockchain to keep track of the privileges of researchers who can access data, and then a blockchain to keep track of who actually accesses healthcare data through this system. So where are we going with this? So the concept of co-design is fundamental to our work, and it may feel that AI is detached from this, but really in order for artificial intelligence to work, we need to be able to get those data, and we see this as a solution for engaging the patient and getting them to provide access to their data with full consent. And so the next step of this is working on a project called the Quebec Smart Care Consortium. You can go to our website, quebecsmartcare.com, to get more information. But in a nutshell, we are bringing forward this concept of smart care, which is the use, which we define as the use of patient-centered data. So again, keeping the patient at the center of their data, so the data to and from the patient, and mobile health technologies for remote monitoring and artificial intelligence research in healthcare. And mHealth Opal is a mobile device, but we're also now integrating in wearable technologies as well. And key to all of this is the concept of co-design. And you can see here the logo of the consortium. And this logo was built deliberately to have co-design as part of it from the outset. And the colors in the logo: green represents patients, blue represents clinicians, red represents researchers, orange represents our industry partners, so those partners with the wearable devices and partners working on AI solutions. And then ultimately the cross at the center represents the healthcare system. And it's really about moving data around between all of these partners in a co-design way, in order to be able to do remote monitoring and AI research on real world data. And in a nutshell, we have Opal that I've explained already, which is a patient portal, and green is for, in the logo, is for patients. So it's the data to and from patients. Blue is the clinicians in the protected healthcare system. So it's working with our clinicians as well. So here you can see the McGill University Health Center data via our technology, and the Opal Pi stands for the Opal Patient Information Exchange. And we have a cloud component to the system, but getting the data in and out of the hospital securely to the patient. Adding in an additional hospital. So we are working with Saint Justine now to have a single app where patients can get their data to and from 2 hospitals at the same time. Ultimately, we hope to bring this into more hospitals, working with the clinicians and the patients in each hospital. And then bringing in the wearable technology. And we've got 2 companies that we're working with. Vital Tracer have built a smartwatch for vital signs, and IMD Research have built a bracelet to get vital signs from patients as well. So getting these data into Opal with Bluetooth, and then getting those data securely into the healthcare system where clinicians can make use of them. And then working with patients to get their consent on Opal to be able to build a research database in the research world, so we can start to get real world data that is coming from patients, and being able to do run AI algorithms on these real world data. And then ultimately it's about also working with our industry partners, because they've got great interests in how their products are being used in the real world healthcare system. And of course, we've got pharma partners and AI partners that are involved in this. And data doesn't easily leave the healthcare system. So you can see here that there's no white line between the hospital and the research institute of the hospital, but there is a white line with industry. So we don't just give data to industry, but we work with industry to make sure that their questions are being answered securely. So this is how we're taking the concept of co-design, working with all our partners. Again, the colors here are deliberate to represent the stakeholders in the system, using co-design to try and get this right from the outset. So my take-home message is co-design can help us build a learning health system. And if you want your AI algorithm to work in a learning health system, you really need to do this. How? By involving all stakeholders in a solid governance framework and working with your stakeholders to continuously learn and improve. So in a nutshell, our learning health system is really all about data. It's all about the technology, whether it's our mobile health technology or AI technology, working with our partners to make sure that we're building a solution that works. Our stakeholders, our patients, clinicians, researchers, industry partners, as well as our healthcare institutions. And then making sure this is all done in a very solid governance framework where everybody is involved and gives input, and ultimately evaluated and have this continuous learning process where information is used to improve the process as we go along. And if we can do this with patients, with researchers, with clinicians, working together, we will build a learning health system that will be useful to everyone. And I just will finish here with a shout out to my team in the Kildea lab, and mention that I am looking for a postdoc and for students to join the team. So if you're interested, please send me an email. Thank you very much.
Thank you so much, Sean. That was really inspirational. We can open the floor for question now, if you have any. So there's a few things in the chat, a couple of them saying about fantastic lecture, many thank yous. Reza saying, oh, Venkatesh.
Hi.
Go ahead.
Yeah, can you hear me?
Yep.
Yes.
Okay, so that was a fantastic John. I am from Western University. I will be joining as a postdoc in loss and imaging, and I will keep this in mind whenever we are doing research. It should be end user focused as well. So I am taking this message seriously, and I will be definitely implementing throughout my career. Fantastic talk, fantastic information. I have a question. My question is, I saw in the Opal there is a tab clinical notes. So I wonder, like, have you guys thought about the negative consequences of sharing the information with the patients? For instance, especially everything being Googled these days, you know, patients of different education, different levels. So it's have you thought in that direction, how much access you provide to them?
Yeah, so that's a great question, and it's something that that does come up. And again, I hark back to the concept of co-design, because by involving our clinicians in the process at the start, the clinicians, of course, did mention this, and it was a big concern for clinicians.
Mm-hmm.
But that concern of clinicians was really balanced by patients who were also at the table, and we had a discussion. So a few things came out of it. First of all, most patients do want access to their clinical notes, to their data, and actually by law, patients, at least in Canada, patients legally can get access to their data. Mm. Of course, in the traditional system, they do have access, but it's very difficult to get access. So we're making that access a lot easier. Mm-hmm. But from a clinician perspective, there is a cultural change. Mm-hmm. So no patient ends up in a hospital or ends up getting a test by accident. Mm. Nobody ends up getting a blood test or getting a biopsy by accident. You don't end up in a surgery getting a biopsy just off the street. You are sent there by the doctor. And before the doctor sends you to get the biopsy, the doctor has an opportunity to explain to you the result of the biopsy. Could be positive or it could be negative. If it's positive, this is what we're going to do. If it's negative, this is what we're going to do, so that it doesn't come to a surprise to the patient later when they're reading the clinical note. And even if it does, as I said, patients don't end up getting a biopsy by accident or getting a blood test by accident. But as soon as they get the biopsy or the blood test, the patient is waiting to get the result. And the patients that we have worked with have explained to us or tell us that the most difficult part of the whole process of getting a test is waiting for the result. And so in many cases, the result is positive, and right away the patient is relieved. In other cases, it's not positive, but the patient now has an opportunity to prepare themselves for the next visit with the doctor, so that when they do go there, they're better prepared to ask the questions, rather than being in a doctor's office and getting blasted with a negative result and being stunned by it and not able to ask the right questions. So yes, it is a big concern about creating anxiety among patients. Our own research has shown, though, that it actually reduces anxiety among patients for the most part.
I see. Okay, that's a nice set of info. It's a kind of a different culture. For instance, I am from India, where the doctor refers for a diagnostic imaging, and the center will directly give the report to the patient, and the patient sees the report, starts googling before meeting the doctor, and ends up in all the confusions. Here, on the other hand, it was very difficult. For instance, when I need access to my data, it was very hard. I have to go through multiple processes to get access. So I was just thinking, from that era of having a barrier to get easy access, it is going directly to the hand. So how it is going to impact the upcoming? But thanks for your explanation. It was fantastic.
No problem.
Thank you.
I think as we build our AI algorithms, we should be able to get better at quickly identifying education material that is not just Google and not just
absolutely
that can go with the clinical notes.
Fantastic. Thank you.
Great, thank you so much. We have a question from the chat from Jay. Thank you, great presentation. Wondering whether we know of any simulator for CT scan machine to communicate with software interfaces for storing images.
Wonder we know of any simulator for CT scan machine to communicate with software interface for storing images. I'm not sure I'm the best person to answer that question. I think maybe you have somebody tomorrow who's speaking about medical images.
Yep. Well, we can go to the next question from Amir Hussain. If we include patients or stakeholders as additional members of the design team, is there a likelihood that the timeline could be extended and the processing speed of designing might decrease?
Yeah, so that's an interesting question. And I would say no. In fact, in the long run, you will have a shorter design timeline. So let's imagine you don't include the end users at the outset. Well, you're going to have to include them at the end because they're the end users. So they're going to be using it at some stage. And if you go through the whole design system and you build something that doesn't work for the end users, you're going to have a very expensive and very long timeline to fix it. So the best time to fix things is before you build them. So I would say you're actually going to decrease the overall timeline if you involve them at the outset. It may appear counterintuitive because yes, it is a lot more work up front, but it's better to get it right the first time than to have to make changes and get something out on the marketplace that doesn't work and is bad for your reputation as well.
Yeah, absolutely agree. And thank you. So I have a question myself. So when you were talking about the entire workflow, and then at the end of it, there's the anonymized data donated from the patient to different research teams. I just wonder what research groups can get those donated patient data from OPA, or are there's an application process or something like that?
Right. So right now we're building the system. We're working with the REB to get the broad consent. But essentially, once we're working with a group at the Montreal Neurological Institute to build our data bank, and we're doing it in an open science context. So when we have it built, there will be a process for getting access to the data. So you'll need to have an REB approved project. But once you have that, we'll be able to provide access to the data.
That sounds wonderful. Do we have more questions? Hussein, I saw you open your camera. Yeah,
I
questions?
would like to, thank John for this talk. It's awesome.
Yeah.
I really originally didn't have a question, but like if you could speak a little bit on ensuring the IT department that adopting the system is a bit safe and kind of convincing them and how that timeline worked out for you, it'd be nice.
Yeah, so I may have given the impression that it was easy. It's not easy. And so even though we have had our IT team involved from the outset, it doesn't mean that they prioritize us.
Yeah,
So it's important that we meet their needs, that we're aligned with what they require, we're aligned with how they operate. But at the end of the day, it is their decision on which projects get prioritized and which projects move ahead at any particular time. I would say that by having patience on the team, it really does help to demonstrate the seriousness of a solution, and it helps to get the prioritization that you need. So don't just be what might appear to the IT team as a selfish researcher wanting your project to advance. It's a project that is, has clear buy-in from all the stakeholders that will help you to move it forward. So yeah, IT teams in hospitals, they're overwhelmed with projects nowadays. There's so many AI projects as well that are trying to make their way into hospitals. They've got limited budgets, so better to involve them as soon as you can.
Okay.
yeah, I was very impressed that, over the years, I've seen how OPAL grows since I guess 2016 was first when I've heard about it, and now 6 years later, it's already made its way into the clinic and actually help patients. That's really, really impressive. What would you say was your biggest bottleneck in this entire process, getting all the stakeholders ready? And
In terms of the biggest bottleneck, I'll be quite honest, the biggest bottleneck was the legal part.
right.
So just moving the legal disclaimer forms, those things that you need lawyers to look at, moving those across their desks can take a long time.
I guess that part took a long time, but the rest, really, everyone's worked together and made the continuous learning.
Yeah, and there's so much
Yeah.
you can do in parallel as well. So try as much as possible not to have everything in sequence. Just do a lot of parallel work.
That's very good advice. Do we have more questions from the chat? Yeah, I think we got a lot of thank yous. Thank you so much, John, for your time today. Oh, Sammy has a question. Go ahead.
Hi, can you hear me?
Yes.
Yes.
My name is Charmin. I'm a resident doctor at SHUM in radiation oncology. Thank you so much for your great presentation. Just a quick question. Like, I love your idea of sharing the data, etc. And I believe you mentioned it earlier that some of the data share can have a quality issue in terms that some people might have some difficulty to interpret the data. Do we have any solution about the QA on the data? Like if those data are accurate and how adequate those data are actually to use? Yeah, so I mean, the approach that we are taking helps us in a sense. So there's the quality of data and there's the interoperability. We somewhat solved the interoperability problem by bringing the data to OPAL. So if they make it to OPAL, then they're interoperable already. So we work with it in that sense. The quality of the data,
you know, it's the data that is put in is the data that comes out is as good as the data that goes in. So there's limits to how good we can ensure the quality of the data, except that we do have an extra set of eyes on the data, and those eyes are the eyes of the patient. And we do get patients looking at their data and saying, this data is not correct. And because for whatever reason, you know, in the clinical note especially, they can find errors and they can question it. So the quality is what it is, and it's a real world database as well. So it's not we're not talking about clinical trials. So I'm not sure if there's any better ways to ensure the quality other than to have these extra set of eyes on them and to learn from our mistakes. Does that help?
Sure. I'm more like talking about not from the patient, but like from upper sig head and neck cancer. You know, HPV positive, negative, those markers. Some ideally those important markers should be noted, but I've often seen that some clinicians do not mark it or forget about it. I was meaning in that sense of the QA, but I think you did answer to my question. Yes, thank you.
Okay.
Right. Thank you for your question, Charmin. Do we have more from the chat? I don't see more at the moment. So, all right. We just want to thank Dr. John Kildea once again for your really engaging, wonderful presentation, for your time this Saturday morning. And as he said, he's looking for postdocs. So if you want to work with him, go send him an email.
Thank you, Eugene. Thanks again for the invitation, and thanks to everyone who turned up on a Saturday morning.
All right.
Or Saturday afternoon, wherever it is.
That's true. We have many countries. All right, I will post this recording online, and I'll send you the link as well, John, as well as to everyone else. Thank you so much. We'll see you tomorrow. Tomorrow we have a seminar at the same time a workshop at the same time at 10:30 for hands-on coding on fully supervised segmentation on medical images. Thank you very much, everyone. See you later. Thanks again, John.
Thank you. Bye-bye.
Bye-bye.